Hello, good morning everyone, and good afternoon to our Louisiana. I'm really excited to introduce to you Dr. Aisha Mays. She will be our faculty speaker on this topic today. Dr. Mays is a family physician who focuses on adolescent medicine. She's faculty at UC Berkeley and the UCSF Joint Medical Program. She's a clinical researcher at the University of California, San Francisco Bixby Centers for Global Reproductive Health, and a founding medical director for the Dream Youth Clinic in Oakland, California. Her work centers on adolescent reproductive health, reproductive justice for highly vulnerable youth, and the health risks associated with childhood commercial sexual exploitation. Her research really does focus on all of those topics, and she is a really renowned and known national expert in this topic. And I would like to hand off the microphone and the controls to you, Dr. Mays. Welcome.
Thank you so much, and thank you everyone for participating in this quality improvement initiative and for your participation in this webinar. And thank you so much for that introduction. So I would like this to be interactive, and if throughout this talk, if questions come up, please write things in your chat box, and I'll make sure to read the questions, and we can have a discussion. And there also will be some points for just further discussions in this talk. And let's see, make sure. There we go. Okay. So just my disclosures. I am an Nexplanon trainer, a national Nexplanon trainer with Merck. I have no financial interest in this topic. So as far as kind of the objectives, what we'll be talking about today is really going over the national recommendations for routine sexual activity assessment for adolescents, talking about when is, based on our recommendations, when is the best time to initiate these assessments, how often should we do them. We'll talk about some of the nuances of confidentiality and how to ensure that with seeing young people alone. We'll also go over implementation tools that we have used sort of in a standardized way. The HEADS assessment, which was already mentioned. We also use something called the SHEADS or the SHADES assessment, a strength-based approach, and we'll talk about how to utilize and implement those into your sexual screening assessments. So sexual history taking techniques, different techniques will be discussed. This will be specifically for consensual sexual experiences. We will provide more information at the end of this talk around young people who may have experienced non-consensual sexual experiences, sexual assault, sexual coercion, and where to provide more information, and also screening guidelines, CDC screening guidelines for that population. But specifically for this talk, we're talking about consensual sexual experiences between two young people. So common concerns that providers can often have when talking about sexual encounters or sexual history include at what age they should start having these conversations, how often they should ask about sexual practices and sexual history. That came up in the earlier CQI project PDSA with, should we be talking about this just annually or with their annual physicals, or should we be doing this in episodic visits as well? How to have these conversations with young people, how to negotiate confidentiality, so how to really ensure confidentiality, which includes negotiating private time alone with young people when they come with parents or when they come with other individuals. And then be able to provide these assessments in an efficient and quick way, and how do we most efficiently utilize our team in order to do that. So overall, why is this even important? Why is it even important to take a sexual history from young people and to really know more information? So we know that when healthcare providers speak to young people about their sexual history, about sexuality, it is an opportunity for providers to promote and support healthy relationships. It is completely within the adolescent development and adolescent timeline, very natural to have feelings of sexuality and to begin to experiment and have sexual experiences. And it's really important to have conversations around sexual consent and healthy relationships. And it's really an opportune time for healthcare providers to be able to support this. We also are able to utilize that time to protect young people and speak to young people about how they can be protected around STIs and looking at asymptomatic disease, why that's even important to be tested. So sort of moving into this next phase of their maturity into adulthood. So how do we know if our patients are at risk for STDs or for HIV? How will we even know this? This is a question I want to kind of throw out to our group. So as people think about that, you can write some things in the chat box, and I'll read our responses. Any ideas of how we know? This also came up in the presentation of the QI project. Julie says, ask if they're sexually active. Like someone else is typing. A few other people are typing. We'll also get a response, question them in a private room. And I see one other question coming in. Maybe that was a duplicate. So both of you all are right, and it sounds like we're on the same page in that. We have to ask. So we have to ask. Providing them education to assess, and it was also a response that came up. But and all of those responses really boil down to this bottom line that we have to ask young people. We can't assume that particular individuals may be sexually active and therefore at risk for STDs and for HIV, and that other individuals may not be at risk. That brings in many layers of bias that ultimately does more harm to the young person if we're not really applying the same standards across all individuals of all communities, of all socioeconomic status, so that they're all remaining safe. So we really have to ask young people, and it sounds like many of you are doing that. And we'll talk about the nuances of how to do that. So we know we have to ask, and we also have support from our academies and our professional institutions around asking. So the American Academy of Pediatrics Bright Futures recommendations, and those are the recommendations for pediatric pediatric health care, recommends that we start asking with sexual activity assessments at the age of 11. So that came up earlier, really starting early, so in this middle school age, and really starting to have conversations with young people about sexual activity, about sexual readiness, even for young people who may not be engaging in any sexual experiences, but having conversations about their emotions and their feelings, and sexual readiness is so important. And then Bright Futures recommends that these ongoing assessments happen at least annually. And we'll talk about how annual is really the minimum recommendation, and that it sounds like many of you will also engage in more frequent recommendations based on activity. So before we sort of jump into conversations and some of the things we're doing around assessments, we'll talk a little bit more about minor consent and confidentiality. As was mentioned earlier, your next webinar will go into the full breadth of minor consent and confidentiality in both California and Louisiana. And so I will just talk very briefly about this now, just for grounding for all of us on this webinar. So in California, in terms of minor consent, for accessing services that are pregnancy-related, which includes contraception, so any form of birth control, also abortion services, or pregnancy services, or prenatal care services, or sexual assault treatment. So all of those things, there's no minimum age that young people can access those without their parents' consent. So that's where the sort of consent piece comes in. Young people can access those services independent of their parents' consent in California. If you have a young person, because there is no minimum age there, again, if we have a very young person coming to access services around pregnancy or abortion or birth control, it would be important to provide some additional follow-up with that young person to understand the circumstances that brought them to becoming pregnant or to desire birth control. Making sure that they're not in a compromising situation or something where they are being taken advantage of. And then for young people who would like to access outpatient mental health services, STI treatment, diagnosis, and testing, including HIV testing, diagnosis, and treatment, or substance abuse treatment. Minors at the age of 12 and up can access those services independent of their parents' permission. So it's not required. Also, written consent from minors is also required for any of these standards under the confidentiality before sharing their information with anyone else. So I see a couple of questions are coming up about what about patients that have any developmental delay, and that's a really great question, and those would be considered in the same way for adults who have developmental delay and going through your state's statutes around their medical care and who's the conserver of their medical care. And so it would require more intervention and more assessment of that person's capacity. And I'm sure you all will also talk about this in more detail at your next webinar with Dr. Guzman. So we're thinking about Louisiana, so in terms of minor consent and confidentiality. And there are some differences in how we in here, so it's really important that we're highlighting this as well. So minors of any age can consent to medical and surgical care or any services at a hospital, public clinic, or Louisiana licensed physician if they believe that they have been affected by what they call venereal disease, which we also call sexually transmitted infections. So if a young person at any age feels like they need to be tested or treated for an STI, they have the ability to seek services in Louisiana without their parents' consent. The nuance and where the difference is that physicians or any other medical staff may share that information with the parent or guardian if they need treatment and sort of sharing that information. And we see that difference in California where the minor has to consent for sharing of that information, and in Louisiana it's really up to the discretion of the medical provider or medical staff. That's something that's really important because, again, when we're talking about the importance of privacy and confidentiality for young people, and we'll look at some future slides around how that really impacts their seeking health care and also sort of going along with health treatment plans. It's really important that we protect minors and adolescents' information and their privacy to be able to provide them with sound health care. So again, even though we can take that into the discretion with providers in certain states, it's really important that we make sure that we are centering the privacy of young people. So you all, again, will have more information about that in your next webinar. So the other thing, again, we've been talking a lot about privacy and confidentiality, how remarkably important that is for young people accessing sexual health care services. Really, this sort of patient and provider time alone is so important. It affects young people's decision to seek care. their disclosures of their behaviors, and which we know is so important in sexual risk assessment, and then their follow-up for care. So following up to be treated for any infections they may have, or just following up to support them around behaviors or risk. And this confidentiality and privacy is also supported by our professional organizations. So really across the board, our U.S. professional organizations support confidential and private time for adolescents who are seeking health care. The American Academy of Pediatrics, the American Academy of Family Physicians, the American Medical Association, the Society of Adolescent Health and Medicine, and the American College of Obstetrics and Gynecology all support this. I like to kind of fall back on those because sometimes, especially when we're talking to other colleagues or even particular parents who might have more questions about this, we also have our institutions that we respect who also support that statement. So when we're looking at young people who, again, going on this sort of privacy and having time alone with providers, we know that only 38% of adolescents aged 15 to 17 had alone time within a healthcare provider in the last year. So if we're looking here around alone time versus non-alone time, and males who are receiving services and females who are receiving services, there really is quite a difference around being able to provide that alone time. And we know that without alone time, it can be more impactful around really accessing the breadth of sexual and reproductive health care services, which we see in this next slide here. This was a study of high school students who were randomized to receive the assurance of confidentiality. So they were provided information that they would receive a confidential appointment or not in a randomized way, and then so what the outcome was. So we saw that students who received that assurance were more willing to disclose information about their care, and then also more willing to follow up with care. So we know that providing confidential services, and part of that, when a parent shows up and when parents don't, because most of the time we don't have parents there. And and for me, I have to also remember that the parents here are not the enemy. Parents often, most of the time, want the best for their children, and I think even for folks who are on this webinar who are parents, we probably can agree with that as well. And so their concerns are really an expression of that. And as providers, we want to make sure that we're providing parents with information around why a shift in the provision of their young person's medical care would change, so that they can also feel at ease. So other tips and sort of tricks around supporting this alone time when parents and young people come together. Something that we saw was done very well in the video is informing the parents about the confidentiality policy before the visit. Either it can happen at the top of the visit, which we witnessed in the video, or something that can happen prior to the young person and the parent coming together, and we'll give some examples around that. Also explaining to the parent with the young person in the room the course of the visit. So explaining the confidentiality, and so that you'll speak together. So you'll all speak together in the room, and then you have the parent step out, and then you'll bring the parent back in at the end to wrap up. So the parent again knows that they're going to be involved in the visit. And discussing confidentiality is just really important at the start. So we already talked a little about this around discussing confidentiality in advance. So we want to make sure the parents are going to be aware of what the policy is around having private time with the young person for confidentiality, and that also will be a part of the visit towards the end. And here are some ways that you can do that. So communicating your confidentiality policy. One example here is to have something before parents and young people come to visit together. So this is an example of a letter that's sort of mailed out to all patients in the practice and parents around the confidentiality and alone time policy, and something that can be sent out to all parents. This can also be used in the school-based health center setting. So I also used to work in school-based health centers here in the Bay Area for about 7 years, and what we would do is include our confidentiality policy as part of this orientation. So at the top of the year, the orientation that was done for all students, we included that into the orientation packet so that parents were also aware. And then this is highly recommended to also post your confidentiality policy in your clinic. So whether you're in a private clinic, in a school-based health center, in a public clinic, in a freestanding teen clinic, to really make sure that that confidentiality policy is posted for parents to see, but more importantly for adolescents to see. So so going back to the importance of adolescents to be aware that their information is kept confidential is so important for them seeking sexual health care services. So we want to make sure that they also know about that. So I would recommend having this in your exam room, and then in the waiting areas, so in the public waiting areas. In our clinic, we also have it in our bathroom. So when our young people go to the bathroom, they can see it there. Some people also have it in the hallways. But having this around so that it reminds young people, it reminds parents, it also reminds your staff around confidentiality for youth. So a little bit more about sort of engaging parents on the day of the visit, which we saw in the video that was done really well. So again, outlining the course of the visit at the beginning, so outlining confidentiality and how the visit will be run, and something that was done really well in the video was validating patients' concerns validating parents' concerns and the parental role, and again, allying with parents around being able to provide care for their young people. So now that we have talked about some of the details and nuances of being able to provide confidential and private care for young people, how we actually implement that in the clinical setting, let's now move on to how we would implement our sexual health assessments, where it actually lives in our visits. And so most of you all have probably been using the HEADS assessment as working with adolescents, and we know the HEADS assessment is a psychosocial assessment, kind of the social history for young people. And has anyone heard of the strength-based risk assessment, and what is that? What is the strength-based HEADS assessment? And people can just kind of chime in on the phone. Okay, so I'll sort of add some to this. So when we're thinking about our psychosocial assessment, the reason why we do that is really to be able to gain context and insight about the breadth of a young person's life, the things that they are encountering on a day-to-day basis. We know that most adolescents are relatively healthy, physically healthy, and they are quite vulnerable to things in the environment. Just as a stage of development, being an adolescent is a time for exploration and experimentation and modeling. And so we know that adolescents can be quite vulnerable to things in their lives. And so we want to understand with whom they're connecting in life, and what things they're passionate about, and helping them to set goals to also be able to facilitate their health. So have people seen this sort of HEADS assessment, and what is this? If folks want to just chime in on the phone.
The SHADES assessment is to make sure that you don't kind of forget anything. So you talk about their strengths, what they like to do, their schooling, how things are going at home, where they live, activities that they participate in, how their friends are doing, drugs or substances, emotions, and their assess for eating disorders and depression, sexuality, and then safety.
Yes, that's exactly right. So it is quite comprehensive, right? So it's giving us, again, this very comprehensive and holistic look into what's happening in a young person's life and things they may be exposed to, and also things that they're interested in. So we use an adapted HEADS assessment called a SHADES assessment or S-HEADS assessment that really is a strength-based framework. And so kind of the difference between the SHADES assessment and the HEADS assessment is the HEADS assessment can really be thought about a risk-based framework, which comes from a more sort of deficit framework where we're just thinking about risk. Like, what is this person at risk of? And so we can help to manage those risks, as opposed to looking at what is this young person, what are the strengths that are inside this young person, or what are the strengths that we can foster and facilitate in this young person. And so let's talk about that first, which is why the SHADES assessment starts with strengths. So what are the things that you're good at? What are things that you like? If you had to teach someone something, what would you teach them? What are the things that you like in your life? And really sort of starting from this sort of more positive framework, and then going through these other sort of holistic measures around that young people are involved in or exposed to. And within that lies our sexuality and sexual history assessment. And that is a Bright Futures recommendation as well. And so this is just a very kind of detailed slide that you all can use as a reference around how to ask questions of young people within this, the strength-based HEADS assessment, the SHADES assessment. And we can specifically kind of look in the purple section here around sex and sexuality, and it has some really good questions around how you would ask questions in a non-judgmental and sort of neutral way to assess what young people may be exposed to or be trying in around their sexual health. So in terms of taking a sexual history, sometimes it's hard to think about how to begin talking about that. Do people have any ideas or anything they'd like to share about how they start a sexual history? And there are no right jump in as they like. So again, oh, go ahead.
I usually just ask, are you sexually active? Males, females, or both? And if they say no, then I usually have you ever been sexually active? Do you have plans to become sexually active?
Yeah, so asking about sexual activity, who they're having sex with, and then I really like the second part of your statement around if they say they've never been sexually active, asking them, have they ever had sex? Because again, when we're thinking about working with young people, depending on their stage of development, some young people can be very, very concrete. And so if you ask them if they're sexually active and they say no, and it doesn't necessarily mean they've never had sex. Right? They could be thinking, oh, well, sexual activity, I haven't had sex for 2 weeks, so I'm not sexually active, or I haven't had sex for a month, so no, I'm not sexually active. And it just really depends on where the young person is in their development. If there's a parent in the room, we do want to have the parent, again, politely asking them to wait outside and talking about our confidentiality policy. Again, acknowledging to that young person that the conversation that you are about to have may feel personal. Again, and I think this is so important because depending on either the age, the development, or the timing of when you're seeing that young person, they have never had a conversation with a medical provider about sex, about sexual activity, about sexual decision-making, about readiness, and so it may feel very uncomfortable for them to have this conversation. So giving them a heads up that what you're going to talk about might feel personal, and why you're talking about it, why that's important. Emphasizing their confidentiality, which we've talked about. And again, explaining why it's important as a provider to have conversations about sexual health with young people, and always bringing it back to really centering the health of that young person and making sure that they have any questions that they want to ask. There's a confidential space to do that, and that you are really allying yourself with the young person. So the ways of being able to sort of taking your sexual history, we think about a mnemonic of the 5 Ps. I really like this, this mnemonic here. The first one being sort of preparation. And I love that preparation is in here because I think that it's really under-discussed when we talk about sexual history taking or sexual risk. It often becomes this very talking about what you're actually doing. So, and as opposed to the preparation and sexual decision-making and sexual consent, and did you feel ready to have sex, and are you happy with the person that you're having sex with, and really talking about that healthy sexual decision-making and sexuality before we start just talking about behaviors. So preparation is really the first thing, and preparation discussions we can have with very young adolescents who have not engaged in any behaviors, but really starting talking about healthy relationships and how they know that they want to choose someone to have sex with. Partners is also on here. So partners, we really think about in different ways, and we're sort of moving away from the practices of asking about genders specifically. And why do you all think we might be moving? So yeah, so we're sort of moving away around genders because gender doesn't necessarily tell us about practices. And we know that risk and sexual risk of particular infections are more connected to practices than they are gender. And also, when we think about sort of gender fluidity, and young people can often have sort of gender fluidity, and also we know that many people, individuals, including young people, are not following along gender binaries. And so asking about gender does not really give us the information that we think that we're getting around mostly practice. Like, are people having what type of genitalia to other type of genitalia? Are they having anal receptive intercourse? Are they having vaginal receptive intercourse? And so really knowing about practices. Also, the number of partners often gives us a false sense of who is at risk for particular infections. So if we have a young person who says that they have a certain number of partners, and sometimes that can give us a sense that, oh, this person might be really at risk and maybe need this type of screening, or maybe need PrEP, as opposed to an individual who says that they have one partner. But if their one partner also has a certain number of partners, or is not using protection with a certain number of partners, that young person who has one partner is also at high risk. And so we don't want to use only sort of sit with partners and thinking about that's giving us solid information about risk, because it really doesn't. We also want to talk about sort of protection from STI. So what type of protection are they using? Are they using protection? And hearing from the young person what they consider protection. Past history of STDs. So if they've had an STD in the past, and were they treated for that STD? Were they then tested for reinfection for that STD? That also helps us with our practices. And then their plans for pregnancy, or their pregnancy history. I also really love this question too, because it is very open-ended around non-judgmental around their history of have they been pregnant before, and are they planning to become pregnant? We know that young people also have desires around pregnancy, and those desires might happen in their adolescence. And according to our minor consent laws, young people are able to make those choices. And so we want to also apply the same reproductive justice principles for young people as we do to adult individuals. And so asking them about their plans for pregnancy also gives us information around how we can then counsel and support a young person around those plans. So this is another sort of way that you can also think about having conversations with a young person around sexuality. So some sample statements. So we thank you for the person in the webinar who also gave a statement around how she talks to young people, or introductory statements about sexual activity. Some things, or do you have any concerns about relationships, dating, or sexual health that you'd like to discuss? That's very nice and open-ended. So it's not, again, just talking about sexual practices, but it's also talking about relationships and really being able to highlight healthy relationships. We have to remember that adolescents are often during the time they're seeing us, there might be some of the very first intimate relationships that they're having with individuals who they're, and we want to be able to support that. Another example, the longer example you all can take a look at is some information on how to have a broader conversation about relationships and sexuality and folding in confidentiality into that. And then we want to ask about, again, preparation. You all can take a look at these, and partners. So again, and we want to sort of, we don't want to highlight, like, are there partners, girls, guys, or both? Again, we want to think about what are the things that that might lend this young person to be more at risk for something, which is really main about more about practices. And so there's some information about practices. And then past STI. So they have ever been tested for an STI, they ever had a positive test. And I see there's a question there. I'll get to that question. And then prevention of STDs. So this is the example question of how to talk about preventing STIs or HIV. What do you do to prevent that? So it could be very open-ended, so you can hear from that young person what they consider to be doing. And then again, pregnancy history and plans. So it looks like there's a question about we have high-risk MSM population in our clinic. Yes, and that is, so again, when we have young people who have self-identified as MSM, men having sex with men, we also want to ask about practices. So we don't want to assume that individuals who identify as men having sex with men are also having anal intercourse, because not all of them are. So again, we want to ask, are you having anal intercourse? Are you having anal receptive intercourse? Which leads to a young person or an individual at much higher risk for HIV infection. Are you having anal penetrative intercourse, or are you having other types of intercourse? Also, again, individuals may identify, have a certain identity as having MSM or identify as LGBTQ, but they also might be having sex with other genders. So individuals who identify as MSM might also be having vaginal intercourse. So again, we want to ask about practices and sort of flesh out and sort of get away from just focusing on identities. So again, things to remember, really want to make any assumptions. I think I hit that one home already. So we're not making any assumptions about practices based on identities, but really asking specifically about practices, being really clear with young people, avoiding medical jargon, so really trying to be very clear as possible when we're asking about practices or activity, and just making it very plain, and asking open-ended questions. Tell me about this thing. And so we can hear from that young person in their own words about what is important for them. Being sort of non-judgmental is the most important thing. I think we all know that when working with young people. We want to make sure that we are not judging them or sort of putting our values, our morals or our values onto a young person's life, but really hearing from them what's important to them, and then being able to support them around the things that are important to them. We often can see that the behaviors that young people may have are not actually supporting their stated goals. And so we can use that as a moment to be able to support behavior change based on their own stated goals, not based on ours. Encouraging our patients to talk in the same way, and then active listening cues, which we saw a lot in the video as well. Good eye contact, body language, non-judgmental facial expressions. So I want to do a quick, just a view of using neutral language. And we can do a quick thing around how to use neutral language. So I would love for you all to chime in here. These are examples of non-neutral language, and maybe you could say how this could be more neutral. So this, why didn't you use a condom? How can we actually make this more neutral language? So we don't want to say that. So more so, what made it difficult to use a condom in that situation? So again, more open-ended, more neutral, and really trying to hear from the young person what challenge they might have had. Did you tell your partners that you were HIV positive? That can make a young person feel very judged, right? How can we be more neutral about that? What's your approach to discussing HIV, your HIV status with your partners? So again, very open-ended, and just asking a young person, how do you talk about this? And if they say they're having challenges with it, we can discuss sort of why they are. It leaves it much more open. Why didn't you finish all of your medicine? Again, a young person can feel very judged by that, very judged by us. It might really shut down the conversation. How can we say this in a more neutral way? What made it difficult for you to finish your medicine? Again, very open, very neutral, really keeping the conversation open to understand what circumstances a young person might be in that made it challenging for them to follow the recommendations that they were given. And if time constraints prevent a full discussion, some things we can do, scheduling a follow-up. So it's really nice that most of us are in adolescent primary care settings where we can, including school-based settings, where we can have the young person come back and continue to have conversations with them, offering them educational resources and apps. Young people love apps, having something on their phone, having something technology related they can use, and providing them a referral if you need to. So if you or your institution is not the best place where they can maybe get more support and more information about this, having a referral source for them that's adolescent friendly. This came up a little bit earlier also in the CQI example around standardizing where we document this information. Standardization is so important so that we know that we're having these conversations, and if we're not having them, we can also see that and be able to go back and have conversations with young people. And we want to have something that's in kind of a queryable field that we then can use for auto reporting, because that's so important as well. So some best practices around this, again, standardizing this alone time. We talked a lot about that. Routinely assessing sexual activity for young people and relationships, using our recommendations from our institutions and our professional institutions, and then also continuing to check in with young people if they are having sex and sexual encounters. And then documenting, again, in a standardized way in our electronic health record. So these are just some tools and resources I talked about at the beginning for young people for whom you suspect sexual assault, having more information here. This talk was really on consensual sexual experiences. And here's some more information on guides to taking a sexual history, and there's you all have that also in your links on the webinar, in addition to these pocket guides and scripts, and these are also linked in the webinar. And so again, we're a resource for you all if you have